Are you able to see the screen?
Yes, ma'am.
Great, great. So again, thank you for allowing us to join. I am trying to advance the slides. There we go. Again, I'm Lisa Hobel-Heinrich, and I'm really pleased to have Anjanette and Shravani joining me. I just wanted to mention right off the bat, none of the presenters today have any potential conflicts of interest with the content of the presentation. What we'd like to cover today is an overview of regulatory issues that should be considered when selecting the right strategy, or regulations that shape particular strategies when we're looking to identify and recruit participants into research studies. Then Anjanette's going to jump in with an overview of research informatics tools in use at KU Medical Center. And then Shravani's going to end the presentation by sharing with us some case studies that she's been involved with utilizing these tools that we're going to discuss today. And before we jump in to talk about the details of those regulatory issues that I'm going to discuss, I wanted to mention a few of the core and other resources that we have through Frontiers, because we won't have time to really dive into those today. And the first is our network capacity core, and Holland Kuo is our recruitment navigator. He is available for assistance in connecting study teams, investigators with local and national recruitment resources, including the resources of the Trial Innovation Network. That network has publicly available a recruitment toolkit that we wanted to mention, with templated pamphlets, brochures, social media templates, and other great information about researchmatch.org, which is another resource to connect volunteers with studies and investigators. I would really encourage you to reach out to him, explore the resources that you have there after the presentation today. I also wanted to mention the Community and Collaboration Core. While we don't have time to touch today on the tremendous importance of community engagement, collaboration, making sure that our studies are broadly accessible to everyone, there are great resources available on the Frontiers website, the Community Collaboration Core. And that includes the multidisciplinary advocates and research group that can provide support for specifically community engagement projects, fostering community engagement process or projects, and design studios and brainstorming sessions where investigators can sign up to either virtually or in person for assistance working through a particular research issue, or an opportunity to get feedback on things, including research strategy or recruitment strategy. So again, that's another wonderful resource that's available to you. And then finally, where we're going to be talking about tools and resources at KUMC today, I wanted to point out that there's also additional information about the informatics core, the Frontiers Informatics Core, led by Jeff Thompson, Dr. Thompson at KUMC, and Dr. Hoffman at Children's Mercy. Again, I'd encourage you, if you haven't been out, to look at the new website and to see the resources that you have there. Please do. We'll be talking more about things like Heron and the tools that they are available to assist with today in terms of how we're using those at KUMC. So with that, I will jump in and start sharing some additional information about issues to consider when selecting a research strategy. And I wanted to start off by touching on something that I think at this point, with our experience with HIPAA, may be obvious, but wanted to point out some nuance there. And that is that it's always appropriate for permissible for healthcare providers in an entity covered by HIPAA to discuss with their own patients the option of enrolling in a trial or a study without patient authorization or without the need for IRB approval or a privacy board if it's separate from the IRB. Now, having said that, for some of us, and that would apply to Frontiers Partners institutions, some of our structures are complicated enough that whether there's a treatment relationship can sometimes be a nuanced conversation. For example, at KUMC, we have a School of Medicine with physicians who are credentialed medical staff with KU Health System. We have other schools on campus where that is not the case for faculty. And so when they're accessing information, they may be guided to a certain pathway that's different than faculty in the School of Medicine, a waiver of consent, for example, which we're going to talk about here in a minute. And so there's a need to just be mindful that sometimes there's a nuanced conversation that needs to happen about treatment relationship and how that's defined under HIPAA. It's also important to remember that there are practical considerations when contacting patients. And while certain things may be permissible under HIPAA, in terms of who has a treatment relationship and might be able to contact participants for purposes of recruitment in a trial, different covered entities can have different policies on what they consider permissible from a policy perspective, whether they want a particular person to be the first person to reach out to a patient to talk about a trial, or whether they want to limit the number of contacts that are made to patients for recruitment purposes. So just wanted to mention here that we always need to be mindful of the different policies that may apply at that institution, covered entity that we may be working with to recruit participants in a trial or a research study. Now, under HIPAA, there is a provision that very commonly arises when we're talking about recruitment, and that's the provision that's called preparatory to research. I have the regulatory citation there, and that section allows an employee or a member of the covered entity's workforce to use PHI, protected health information, to identify prospective research participants for purposes of seeking their authorization to use or disclose their PHI for a research study. Now, it's important that the covered entity get representations from the researcher that that it's for research, that they won't be removing PHI from the covered entity. And that's an important thing to remember with regard to this provision. PHI cannot be removed from the covered entity site. And so what that means is that when we're talking about individuals who are researchers who are not workforce members of that covered entity, they may not be able to rely on this section to actually contact the prospective research participants for that study. And so it may be that they would need to think about obtaining a waiver of consent, a partial waiver of authorization from the IRB and for HIPAA purposes as well, not just under the common rule, if that information, if they'd like to be using that information to actually make contact for recruitment purposes. This is something we're starting to see come up more often as we have investigators who are collaborating with, say, rural health providers, physician practices, for example, and perhaps that clinic may want assistance in identifying patients of theirs who may qualify. Reliance on the waiver approach, if approved by an IRB for some reasons, may be the best approach because in the long run there are reduced administrative burdens that may attach for the covered entity and the researcher. We don't have time to get into all of the details around that, but if that is something that you would like additional information about, I'd encourage you, reach out to your IRB office, reach out to me. I'm happy to talk through that with you. Our privacy officer is another great resource for that, Chris Griffith. I'd also like to mention the issue of research registries. When investigators, study teams, a physician wants to create or maintain a registry or a database, or even just a list of individuals' names and contacts for future use for purposes of future research studies, that activity itself crosses the line into research under federal regulations. And so if you have a coordinator who maybe wants to start creating a list, pulling names out of a medical record, for example, and keep that for future use, that activity itself, as well as those future research studies, needs IRB approval as a research registry. Now, there is some leeway if we're only talking about collecting names by a study team to participate, or participating in a specific study, and they may want to contact those participants for a future study, and it's the same research team, provided there's appropriate language in that consent form. That consent form is approved by the IRB ahead of time. That may be permissible, but if we're talking about keeping lists, creating a database, something like that, and then, for broader use in future research studies, that will need separate IRB approval. When we're talking about advertising, whether that's putting up, a poster where people can pull off a number, or, sending something out on social media, whatever the case may be, that's when we're talking about recruitment materials that need specific IRB approval. When we're talking about publicly facing information that goes beyond a directory listing with basic information about this study, which I'll talk about here in a second, that information is considered part of the informed consent process and therefore requires IRB review and approval. If the information exceeds listing basic information about, or if it crosses into information rather about the risks, benefits, or is soliciting identifiable information, those are the things that we really would also need to be paying close attention to. And when there is guidance from the Office of Human Research Protection, that is the agency that has promulgated what's known as the common rule for human subjects research. There is guidance that talks about this. If you've never read that guidance and you're going to be engaging in advertising and promoting marketing for a study, I would encourage you to Google that and take a look at it. That guidance does say that if you have if what you're doing is just sharing basic directory type information, study title, the purpose of the study, maybe a summary of the protocol, basic eligibility criteria, the locations of the study, a contact name, and they actually list this out, that it does not require IRB approval. I'm going to go back to the prior slide. It's when you start including the additional type of information that you see here that you need that. So when we're talking about a directory like clinicaltrial.gov or National Cancer Institute, or our Cancer Institute has a website too. What I'm showing you here now is the Frontiers Trials Today website. If you haven't seen that yet on the new website, I'd encourage you to take a look at that. These types of directories do not need IRB approval, and it's always good to rely on them when possible. So what does an IRB look at when they are considering advertising content as part of an IRB application? First, they're going to be looking at things like the information in the content. Is it accurate? Is there discussion about the risks or potential benefits? And would that be misleading, or would it imply benefits beyond those benefits that beyond those potentially provided by the research? Do they potentially, does it have incentives that might compromise how a participant would think about that and the voluntariness of their choices in considering whether to enroll in that study? Are there adequate plans to protect the information that might be collected? Oftentimes you'll see, for example, there may be a posting or a social media where there's a link where people can go in and get additional information, or perhaps even put some of their personal information to be contacted. Is there a clear explanation of what that is, how it would be used? And depending on what it is it something that would require a waiver of informed consent, either under the common rule and under HIPAA? So those are really important considerations before going forward with the advertising. And I also wanted to point out that if you're talking about video recording or audio recording and including that, remember to follow up with your IRB and provide the scripts for those before going so far as to record them. That way, if the IRB comes back requesting changes, they can be reflected in the recording without having to backtrack and create more expense, time, and effort. I wanted to point out that the NIH does have guidance about social media tools, and I'd encourage you to take a look at that as well. They talk about things to, oh, I'm sorry here. Talk about things, privacy practices, being mindful of the platform that's being used, understanding how it is it's going to be used. If you're using an outside provider to share that information or to distribute that information, be very clear on where they're going to be posting it so you're not surprised about that. Because that information in interactive media is not static, you may want to lock down that document. Again, you don't want to be having changes to things that have already received IRB approval. And I mentioned before things, like including a link where people might put information into REDCap or something to collect that information. Consider the need to have a IT security plan. Where is that information going to be stored? Make sure the IRB is aware of what's going to be happening. Understand the invasive nature of joining groups where you might want to be recruiting, thinking through that, and making sure that the complete strategy for the use of whatever media, advertising, brochures that are going to be used are explicitly covered in the IRB application to make sure that there's that appropriate review and approval ahead of time. Something that we're seeing more frequently, even just in the past year, are sponsors offering recruitment bonuses. And what I mean by that are payments to an investigator or staff or a research site based on the number of participants enrolled or the speed of enrollment. And I wanted to mention that those kinds of payments can create conflict of interest concerns, IRB concerns. IRB approval is required at KUMC. So we want to make sure that the IRB was made aware if a study team was wanting to explore that. But at KUMC, we do have policies about that restrict that activity. Some of the concerns that can arise when those kinds of arrangements are made are perceived pressure to enroll less appropriate participants, or potentially encouraging inappropriate pressure on patients to enroll. When we're talking about healthcare providers and referral sources, pharmaceutical companies, for example, there are also state and federal statutes that place prohibitions on activities that are providing remuneration based on the volume or value of referrals. And so those anti-kickback statutes can also create concerns in those instances. So, be careful when presented with arrangements like that. Please reach out for guidance. Increasingly also seeing discussion about referral programs in which incentives may be paid to study participants or others to recruit or provide names or things like that. Those also must be reviewed by the IRB. There are potentially programs which I know at some institutions have been approved. Again, I think reaching out early to the IRB to talk through that, or your compliance office, is really important. Employees as research participants is something that also comes up quite commonly. And we always want to make sure that our employees have fair access to research and to clinical trials, for example, that might benefit them. But we also have to be mindful that recruitment has to be done in a way that minimizes the possibility of coercion or undue influence. And so, there's a variety of different things that could be done to help with that. For example, putting up sign-up sheets or postings or other methods where the employee themselves would express interest in the research instead of the investigator approaching employees. We have to be mindful of safeguards to protect the privacy of any employees who would be enrolling. And if it's a situation where the investigator has a status relationship with that participant, whether they're a member of the study team or an employee under supervision of the investigator, for example, there's special ethical concerns that arise in those circumstances. So when those kinds of activities occur, it's important to make sure the IRB is aware and that they're helping that investigator take a look at that and determine whether additional protections are required. I wanted to briefly mention other issues that can impact recruitment as well. That could be, not being aware of other trials that may be going on and competing for the same patient pool, for example. It could be inclusion or exclusion criteria. We sometimes see our QA team who works with study teams sometimes see, for example, lab criteria being added when there's no outcome or safety measure, incorporating those values. And so putting in place things that aren't really necessary, might negatively impact recruitment. Of course, being sure that there's the budget and the staffing and a clear understanding of sponsor requirements is also always important, and in that upfront planning for the trial. And then finally, before kicking it over to Anjanette, I wanted to just mention briefly, when we're talking about decentralized trials, and I'm sorry, these keep jumping ahead here. I'm sure there's a setting that I don't have right here. But with regard to decentralized strategies to enhance enrollment, whether we're talking about telehealth, mobile healthcare, local healthcare providers, home health, e-consent, or whether there's an investigator-initiated trial, could we deliver investigational product to someone's home, things like that. It's important to think through issues of licensure. If we're talking about an investigator who is doing a multi-site trial, perhaps with sites in another state, if they want to be engaging in activity, is there licensure professional liability in place? If we're involving providers, a local healthcare provider, for example, are we asking them, just to do what they would do as a primary care physician, or are we asking them perhaps to collect data for that trial in a way that might cause them themselves to be engaged in the conduct of research? And, in cases like that, we may want to work with them to make sure that we've done what needs to be done from an IRB perspective with that site, for example. And or depending on what the situation is, whether it's a local provider or a home health provider, depending on the activity that they would be involved in or supporting. If it's, just to give an example, if it's an FDA regulated study, they may need to be included in the delegation of duty log. And that we may need to be very clear about how we're documenting that activity. I have here just a slide, and we'll make this available, but I included here contacts we have at KUMC. Jennifer Pennington is our recruitment, or excuse me, our regulatory knowledge and support navigator. There'll be links to other resources we have here for graphic services or paid media campaigns. I've got the link to the Trials Today site for Frontiers. And if anyone would like to look at having third-party vendor support for recruiting, whether that's social media or anything else, please reach out and let us know, and we're happy to help you with that. So with that, I am going to kick it over to Anjanette. And Anjanette, I'm going to stop sharing on my end.
Sure.
That you can pick it up from here.
Okay, thank you. KUMC, and I'm going to talk about the research informatic tools that we have available. The first, what we do here in research informatics is we provide a self-service informatic tool service for you to get feasibility counts, cohort discovery, recruitment, data analysis, and collaborations with external researchers.
Sorry, Anjanette, we're still seeing.
Although I just navigated to the slide where I'm supposed to be speaking. Here you go, Angie.
Okay.
Do you want to talk about it, and I can
Yeah, thank you so much, Shravani. Yes. So yeah, I'll talk about what we do here in research informatics. We provide self-service tools for the informatics data collections for feasibility counts, cohort discovery, recruitment, data analysis, and collaborations with external researchers. Utilizing our I2B2 tool, Heron. And what that is Heron is a self-service tool which allows you to get feasibility counts. And for, excuse me, for external collaborations, we have another tool called Green Heron. And also, research informatics also offers electronic medical record databases used to conduct high volume research, such as utilizing Cosmos. And Cosmos is our a really large integrated database that it allows you to query millions of patients in a matter of minutes, and you can get a representative sample of data that looks like the United States Census. So what it does is Epic is integrating the inpatient and the outpatient medical record into a single comprehensive record for a detailed picture of the patient's health, and that will be utilizing Cosmos. We also offer support to the Cerner Learning Health Network, and this is another large de-identified health data resource where the electronic health record is from millions of patients combined from multiple institutions, including our own. The Learning Health Network has an analytic interface to the data set, and this allows the researchers here, or the research informatics department here, to work with researchers here to do studies. So the de-identified data set is scanned to look for potentially eligible patients, and if any are found, then those contacts at those institutions are notified and they can find researchers who might be interested in participating in a multi-site study of some kind. The Learning Health Network can help improve enrollment times by efficiently locating and enrolling patients at the start of the study. But this is a Cerner product, so Cerner will help coordinate the next steps. We also have another research informatic tool that we assist with where you can receive clinical research notifications, patient communications, and automated pre-screenings by using what's called best practice advisories or alerts. And we also have another tool called Research Recruitment via MyChart, or you can use the reporting workbench. And I'll talk more about what those are in just a moment. But we also here in Research Informatics offer REDCap support, which is an electronic data capture tool for building online surveys or data management. And we also support with participation in research networks, where we provide support of collaboration opportunities for investigators and researchers. We offer support to the GPC, which is the Greater Plains Collaborative. This is a network of 13 leading medical centers, which brings together a diverse population of over 34 million patients covering 9 states. We offer support with GROUSE, which is the GPC's reusable observable study environment to obtain health insurance claims. And then we offer support to N3C, which is the National COVID-19 Cohort Collaborative. And this is one of the largest collections of secure and de-identified clinical data in the United States for COVID-19 research. We support the 4CE, which is a consortium of clinical characterization of COVID-19 by EHR. And so we also have one more, which is called the All of Us research program that we support. And this is a National Institutes of Health project that stores health data across a wide range of settings and institutions from a diverse group of participants from the United States. And we also have in Research Informatics Department, we offer project development, consultation, data analysis support. We have lunch and learns and office hours for project assistance and consultations. And we have me, the Research Data Concierge, who can help assist with project development, guidance to resources, contacts, and research support. So some strategies for patient identification and recruitment include using these tools. We recommend using these tools: Heron, C3OD, Best Practice Advisories, MyChart, or the Reporting Workbench. So the first tool we recommend using is Heron, because Heron is a self-service tool. And this allows you to go in and use this tool yourself to create a query of data sets and rapidly identify population characteristics, feasibility and cohort discovery, eligibility of planned clinical studies, and to enroll subjects in a study to explore a hypothesis using retrospective data. Or you can use this to apply for a grant. There's a process before you get into Heron. There's a link here that you would click to start the process, which is a REDCap form. And then once that request is filled out, it comes to us in Research Informatics. There are a couple of items that you have to complete, such as having a secure KUMC network, either on campus or VPN, or be a faculty member or sponsored by a faculty member. And we have a sponsorship request page that you would get into. We also have something called an affiliated account request if you're not on campus. And then there's, we would ask that you have up-to-date human subjects training. So once this sponsorship is submitted, the DROC committee receives that request for approval, which is the Data Request Oversight Committee. And you can execute a system access agreement form. You log into Heron, and there it is. You go in and create a search and obtain a data set. Once you obtain that data set, you can request if it's identified or de-identified, and DROC will review that request and they will either approve or deny it. And then they'll send a research informatics secure file via REDCap. So this is just an overview of the process, and we do offer training and support for Heron. You can go to the next slide.
Anjanette,
Yes.
given the time that we have, I'm wondering if we might jump to the slide that provides a summary for my chart,
Oh, yes, yes.
the
Okay.
workbench.
Yes.
C3OD,
You-
you have in here wonderful information, very similar to what we
Yes.
just talked about for Heron.
Yes, yes, those are the C3OD process is similar, so we can just skip over that. It's just the same process basically, but it's just for cancer related studies. So going on to the EPICO tools, they require that you have access. That's the very first thing that's important about using EPICO2 is that you have to have access. And that goes to best practice advisories, my chart, and the reporting workbench as well. So you can go to the next one, Shravani. Thank you. Best practice advisories are for point of care and to identify who might qualify for a study. And I'll just skip over, that's what it's for, is just using the point of care recruitment strategy. And it will basically, a clinician has the option, an enrollment record is created at the patient for the patient with the applicable initial status, such as identified, interested, or declined. That's using a BPA, but BPA should not be considered as an initial screening tool, not necessarily a way to determine full eligibility, but just a way to determine identification. So the My Chart is, you can go to the next one, Shravani. The next one, My Chart is another tool, and it's a recruitment way to recruit patients directly. To successfully receive a recruitment request, a patient must have the My Chart security access, and when a patient is identified, details about the study will appear in My Chart along with other studies. And the patient indicates whether they're interested, and then an in-basket message will be sent to the users at your organization. And then there's also reporting workbench, which is basically just a report that is sent to the research coordinator, and it can be made into a dashboard. And you can go on to that. And so that's another EPICO2. It's the same process for all three EPICO2 workflows. Okay, thank you.
All right, Angie, you gave me 13 minutes to talk about my favorite topic. Let's see how that goes.
Thank you. I'm sorry about that, Shravani.
All right. So to summarize what Lisa said and what Angie said, this is a case study / a PICONET study that we implemented here using all the tools that Angie described, following all the governance protocols that Lisa described. This is a PICORE funded study, the Patient-Centered Outcomes Research Institute funded study. And this is a little information about the Greater Plains Collaborative. There are 13 universities, and you could see geographically which universities are situated where. And like Angie said, we have over 30 million patients in GPC. If you collaborate with us, you'll get access to those patients. And this is a study designed for adaptable, and you keep hearing a computable phenotype quite a bit when you are working in collaborative research. It's nothing but inclusion-exclusion criteria that the lead site defines. And here the workflow is the patients with ASCVD with one or more than these enrichment factors described here, greater than 65 years, creatinine, diabetes, and all these other factors listed down. The workflow is we identify the patients at our site and then reroute them via an electronic method. The adaptable study was advertised as the pragmatic trial, and we did not want a whole lot of manual work. We wanted to try it out to see all these tools that are at our disposal, like Heron and MyChart communication first, because that's the lowest hanging fruit before we bring in a lot of study coordinators onto the trial to see how that works. So we identified the patients in a Heron environment, and then the patients are contacted electronically through email, and they will be routed to a portal which was purchased by PicOrNet, and Duke University was managing that. The name of the tool is MITRIS Portal, and the e-consenting process for all of those patients was happening within MITRIS. And these are the study randomization criteria. There will be patients that are put in the 81 mg category and 325 mg, and there will be an electronic follow-up. And this information is also supplemented with claims data. And the duration was 24 months with several follow-up appointments lasting up until 30 months. So I'll show you how we took this inclusion exclusion criteria and replicated it to fit to our site needs. So this is a huge query. 263 terms were dragged and dropped into Heron. I do remember the exact number of the terms that I dragged because this was primarily my baby when I was working on this project as a data manager. So we could tailor it to our needs. You know, the inclusion exclusion criteria from the lead side could give us the basic inclusion exclusion, but what works best for our recruitment, like only including the patients who have consented to receive email, making sure we are only including patients who had some sort of treatment connection with KUH in the last 12 months. So we could add all these additional criteria to make it work best for our site is what we did using the Heron query here. And the primary recruitment strategies back in the day, we did not have a working partnership with the KUH team to implement MyChart. But what we did as KUMC, we created an adaptable at kumc.edu, and we sent all these emails out to patients. And we just tried out hard copy letter mails for only 1,000 patients. And here are some statistics. And as you can see, these are all the GPC sites that participated in the study, and our site is the only one which recruited 737 patients. And we only got one recruitment from the mailers that we send. We only tried with 1,000 patients at that time, but by far the best strategy that worked out for us is electronic. And also I must emphasize that there were different strategies that were followed. You know, after you send the email, we wanted to make sure there were instances where we noted that the patient went to the portal, but somehow they did not get randomized. That's an indication that the patient showed interest to click on the link, but never really consented. So we were always starting off like going to the portal. We all had access to the portal on the KUMC study team. We used to go look at that list every week and start making phone calls to those patients just to see what prevented them from consenting. If there are any clinical questions that our nurses could answer, we always targeted, and that approach by far has yielded a good recruitment count at our site. And I must emphasize that next to Vanderbilt, Duke, and all these big universities that have these big call centers making calls for these recruitments, we stood fourth in the country for adaptable recruitment. And just taking that adaptable as an example, we wanted to try the same approach using our infrastructure that we support at KUMC. You know, the MITRIS portal was nice, but it involved a lot of, money involved. So what we wanted to see is we support RedCap. Our team manages RedCap. So what we decided was replicate that entire e-consenting process in RedCap. And when we are contacting the patients, the email, we identified the patients again using Heron for the Down syndrome population, which I must say that it's a underrepresented patient population. And this DIAS determined study involved rerouting the patients to the NIH's DIAS Connect portal, where they have to fill several survey forms. And then we also have the self-determination inventory at KU Lawrence campus. Once the patients are done completing the survey at the DS Connect portal, they will automatically route through the SDI, get routed to the SDI inventory at Lawrence campus. And we will be receiving feedback from these both systems, DS Connect website and SDI, on the status of the survey forms that the patients have filled. So if you fill both surveys, you get $50. If you just fill one survey, the patient gets $25. So we built that entire pipeline using REDCap alone. Our engineers were working with engineers at SDI and DS Connect to make that happen through the API flow. As you can see, the quick workflow is we identified the patients within a Heron, and it comes to the e-consenting happens in REDCap, and they're routed to DS Connect and the self-determination in inventory. And similar recruitment methods, we don't have a whole lot of Down syndrome population, so we try to stick with email and REDCap invitations for this study as well. And here is how we identified the cohort. And this is how the trial invite codes are sent. And all the while, SA is, this is a 4-site trial. Site A is KUMC, and we have MU, Alina Health, and University of Pittsburgh who are also participating, KU being the central site, which is managing all these emails that are going out. We de-identified the patients in a way by giving the Charlie and the Chocolate Factory Willy Wonka analogy, like the golden ticket code. Similarly, we have a trial invite code that gets sent out to patients at respective site, and the study coordinators have access to the project to send emails from this REDCap system. And here is how a recruitment email, an IRB approved content could be sent in a REDCap message. And the consenting, there were 3 consents that were involved. One is to participate and share your EHR consent, and consent to participate in DS Connect and SDI. And all of that consenting was done in a REDCap form here. And here is how you go log in, register to DS Connect enrollment. And this is where we were receiving feedback about when did the patient go start the survey, when did they complete, so that our study coordinators know this information getting updated overnight is key for us to distribute the gift cards. And same is the case with the self-determination inventory. And as a high-level data deposit, we have all of these patients recruited from all of these PICORnet sites. Now we could de-identify all of this data and put it in NIH's data repository using a PICORnet common data model is what we call for the patients who have consented. And also partnering up with the Heron-like systems, you could also change recruitment strategies. If you have any patients who have their appointments coming up, who are eligible for the study, our team could also help you get patient lists like that. And also there are flyers that you could share, which could also be broken down by race and gender, if that's what you're interested. So yeah, if you guys are interested to know more, please reach out to OCRIO support. Angie or myself will be happy to collaborate with you. Any questions?
Thank you. That was a wonderful presentation. There was a lot of great information. Is a lot of this information on the Frontiers website as well, or are there resources to, I guess, maybe get people to you to learn more? So, because there was a lot of great information. So,
Shravani, do you want to jump in first?
Yeah, I believe most of this information is on our KUMC research informatics page, but I'm Kelly Hale probably could be able to answer your question about the Frontiers website.
Mm-hmm. Dr. Jones, I also wanted to mention that I had on the last slide that I showed, I included links to the research informatics website, as well as links to the IRB, links to the Navigator. On an earlier slide, I had the information to contact the Frontiers Recruitment Navigator. This information is available through the New Frontiers website. Again, I can't recommend that enough if folks would go out and look at that. If you have any question or difficulty contacting anyone, you're always welcome to reach out to the three of us, and we'll be happy to connect you.
Okay, thank you. I don't see any questions in the chat. And I know we only have 1 minute, but I had one question about the email contact. I was actually kind of shocked that you got such a good response from email, because I feel like your email inboxes are so full all the time and people would tend to ignore emails. So was there a way that the email was written, or the message in the title line? Was there?
So, yeah, that's a good question. And what we did was, instead of sending emails from our personal mailboxes, we worked with our KU's IT team to come up with an email address relevant to the study. In this case, it was adaptable@kumc.edu. And the PICORnet also has a great patient engagement team who could also, give you suggestions about what the title of the email is and what time of the day you're supposed to be sending your emails, what time of the day that works best for leaving voicemails if your patients are not answering your phone calls. So we provide so much recruitment strategy support that way. But by far, adaptable@kumc.edu made it look like it's not a spam email.
Yeah, okay. It's amazing. All right, well, we are actually over time. So with that, thank you again. I hope everyone goes out and checks out these resources and reaches out to the team. Thank you so much.
Thank you all.
Thank
All
you
right,
for having
have a
us.
great day.
Bye.
Thank you.